Today's conference will review the health and care issues and needs of all migrants, celebrate what has been achieved, and look at action needing to improve health provision across the region for new and emerging communities. I wish you a successful conference, and all of us at the NESMP board look forward to the recommendations arising from today and ensure that our delivery board facilitates its implementation. And I'm delighted to introduce our first speaker, who's the chair of the North East Equality and Diversity Partnership, Ranjana Bell.
The Regional Development Agency, One North East, decided a couple of years ago that we needed to have a regional lead on the issues around equality and diversity that cover the whole region, not just Newcastle, not just Sunderland or Teesside, but the whole region. And in terms of health needs, health providers in the region have found a particularly high prevalence of mental health issues, which is what I mentioned earlier, amongst this group. So there you go. There's the challenges to all of us. I think we have a responsibility to try and find out the facts. So working with agencies who do this work every day, we should be sharing information, talking to people themselves who are in the receiving end of the healthcare needs and treatments. So I am going to shut up there and wish you good luck. Thank you.
Our next speaker, Anita Bell, UK Border Agency.
So my name's Anita Bell. I'm one of the operational managers for UKBA. Thought we'd start with what the definition of asylum was. I know Ranjana talked about the definition of migrants. So that's what we use as the definition of asylum. So everyone has got the right to make an asylum application, and as long as their asylum claim remains undecided, they are an asylum seeker. Okay, so that's pretty much all I wanted to say. I know we've got some sort of panel discussion afterwards, so if anyone's got any questions, feel free to ask. I'm not sure whether I can answer them all. I have also, there's a stand outside where I and two of my colleagues will be, so if anyone doesn't feel comfortable asking questions in the open, feel free to come and speak to us afterwards. Okay, thank you very much.
The next speaker, I hope I get the name right, is Beanie Araya.
Well, thanks very much. You'll be glad to hear that I've only got 2 or 3 slides, but I'm here just to give you a slight overview of the forum and what it does. This is a refugee forum run by refugees for refugees. We are a totally independent organization, and we strive to make a genuine representation. That's about what I would like to say. So welcome, Refugee Community Organization is up to the platform.
Right. We aim to reduce FGM in Teesside, but we are also hoping to extend it in the Northeast. So what is FGM? FGM stands for Female Genital Mutilation, and it involves procedure that intentionally alter or injure female genital organ for non-medical reason. An estimate of 100 to 140 million girls and women worldwide are currently living with the consequences of FGM. And in Africa, about 3 million girls are at risk for FGM annually. The procedure has no health benefits for girls or women. It is mostly carried out on young girls, sometime between infancy and age 15 years, but sometimes they perform it on adults. If that lady wants to meet the criteria within her community, if she wants to be accepted within her community, then she will go through FGM. FGM is internationally recognized as a violation of the human rights of girls and women. As you can see, the instrument there, that's what they use to perform FGM. The practice is mostly carried out by traditional. In Africa, old women are considered to be wise, to have more knowledge. So they are the one carrying out FGM, or even they can perform childbirth. FGM is carried out with special knives, scissors, scalpels, pieces of glass or razor blades. And those ones are not new. They can use the same instrument on different girls or different women. So this refers us to HIV. They don't use any anesthesia, any antiseptic, and sometimes in communities where infibulation is carried out, the legs of the girls are bound together to immobilize her for a period of 10 to 14 days to allow the formation of scar tissue. Right. This is a normal picture of the female anatomy. As you can see, everything is right in their place. Type 1 of female genital mutilation, which is also called clitorectomy, it involves excision of the skin surrounding the clitoris. I don't need to go there because I'm sure we all know where they are. So the clitoris can sometimes be removed or not being removed. When it is performed in infants and young girls, a portion of or all of the clitoris and surrounding tissues may be removed. If only the clitoral prepuce is removed, the physical manifestation of type 1 FGM may be subtle, necessitating a careful examination of the clitoris and adjacent structure for recognition. Type 2 of FGM, or also called excision. This includes the removal of the entire clitoris and part of or all of the labia minora. So crude stitches or gut cut or turns may be used to control bleeding from the clitoral artery and raw tissue surfaces, or mood poultices may be applied directly to the perineum. Patients with type 2 FGM do not have the typical contour of the anterior perineal structures resulting from the absence of the labia minora and clitoris. The vaginal opening is not covered in the type 2 procedure. Type 3, or infibulation, as I mentioned in my previous slide. Type 3 FGM, known as infibulation, is the most severe form of FGM, in which the clitoris and some or all of the labia, as you can see the picture there, is removed, so excised. In type 3 female genital mutilation, the patient will have a firm band of tissue replacing the labia and obliteration of the urethra and vaginal opening. I always take the case of that lady who went through infibulation in my country. They performed infibulation on her, but unfortunately, it wasn't done properly, and everywhere was closed, so she couldn't pass urine, or even her sex was swollen, so the blood was also stuck inside. She was in terrible pain. She was crying her head out. And what they did, they took her to a clinic, but they said they will perform it again. They said it's because they did not do it properly, so they will come and do it again and make sure it's done properly. I brought this real picture to show you how, in reality, it's presented. Type 4 includes different practices of variable severity, including pricking, piercing or incision of the clitoris or labia, stretching of the clitoris and labia, cauterization of the clitoris, and scraping or introduction